Moving on to the shoulder joint. The correct term for the shoulder joint is the glenohumeral joint. Looking at the articular surfaces, first of all, we can see that the glenohumeral joint is a typical synovial ball and socket joint. It's close packed, in other words, its most stable position is with the arm abducted and externally rotated. The articular surfaces are the head of the humerus, which is hemispherical in shape. It's orientated upwards at an angle of about 140 degrees and posteriorly at an angle of about 30 degrees. It's a typical synovial joint, so therefore the articular surfaces are covered in hyaline cartilage. The socket part of the ball and socket joint is the glenoid fossa. Here we can see the scapula from its lateral view. So this is the glenoid fossa. It's a pear-shaped biconcave structure. This is the acromion process coming off posteriorly. So there's the spine of the scapula, acromion process. Over here anteriorly we've got the coracoid process, and down here we've got the remainder of the scapula. It's biconcave in shape, it's covered in hyaline cartilage just like any other synovial joint, and anatomically it faces anterolaterally. It's angled forward by about 30 degrees. There is a significant difference in the size ratio between the head of the humerus and the glenoid fossa itself, with the glenoid fossa being about a quarter of the size of the head of the humerus. This poor size ratio leads to an increase in mobility of the joint itself, and therefore a decrease in stability. In addition to that, where the head of the humerus is hemispherical in shape, the glenoid fossa is relatively flat. So not only is there this poor size ratio, but there is a poor congruence between the articular surfaces, further increasing the instability of the joint itself. The glenoid fossa is deepened by a structure called the fibrocartilaginous glenoid labrum. This improves the size ratio. It shifts it from being a 1:4 to about a 1:3. And here we can see the labrum, this structure coming all the way around the edge of the glenoid fossa. So again, we've got the acromion at the back there, coracoid at the front, with the coracoacromial ligament in between the two. Here is the biceps tendon, the tendon of the long head of biceps that goes off and blends into the top of the glenoid labrum. And the labrum is very similar. It's comparable to the labrum of the hip joint. It's triangular in cross section. The main difference is that the labrum here is complete. It forms a complete oval, so it follows all the way around the glenoid fossa. The shoulder joint is a typical synovial joint that, and just like any other synovial joint, it has a synovial capsule. The capsule of the shoulder joint is a loose cylindrical sleeve that passes from just beyond the margins of the glenoid fossa, and it extends down onto the humerus. It passes down to the anatomical neck of the humerus here, anteriorly, superiorly and posteriorly, and down as far as the tubercles over here, and inferiorly it passes down to the surgical neck, or the medial aspect of the shaft of the humerus. The capsule is reinforced posteriorly, anteriorly and superiorly by a group of muscles that pass like fingers from the scapula to the humerus. These are the rotator cuff, and the tendons of the rotator cuff are important stabilizing structures of the glenohumeral joint. The capsule is a very loose structure. It needs to be loose, it needs to be lax in order to allow for the large range of motion. In particular, what we note is a significantly lax component down here on the inferior aspect of the glenohumeral joint to allow for the large range of movement into abduction and into flexion in particular. Not only is the capsule lax, but there is an opening in the capsule, and the opening in the capsule is there to allow the tendon of the long head of biceps to pass through. Here we can see this blue structure we can see coming up through the intertubercular sulcus, in between the lesser tubercle there, the greater tubercle there, passing over the head of the humerus before going off and blending into the labrum. On the superior aspect of the glenoid fossa is the biceps tendon, and in order to get there it needs to pass through the capsule. So there's an opening here on the anterior superior aspect of the capsule itself. The tendon itself is stabilized by a thickening in the capsule. So this red structure that we can see here is often called the transverse humeral ligament. And the transverse humeral ligament realistically is a thickening in the capsule, and it serves to stabilize the tendon in its sulcus. If the transverse humeral ligament were to break or tear, as it does occasionally, the long-headed biceps tendon can sublux in and out of that sulcus, sublux in and out of the bicipital sulcus. The capsule is reinforced anteriorly by 3 ligaments. This green one here, we have the superior glenohumeral joint ligament passing from the upper part of the glenoid and blending with the labrum to just above the lesser tubercle. Then we have the middle glenohumeral joint ligament, which passes from the anterior aspect of the glenoid fossa to just below the lesser tubercle. This red one here is the inferior glenohumeral joint ligament, passing from the anterior border of the glenoid fossa, extending down to the neck of the humerus. This is the most important of the 3 ligaments, as when we abduct our arm, this acts like a hammock, like a cradle for the head of the humerus to drop into. An interesting point to note is that the middle glenohumeral joint ligament, this blue structure, is absent in about 30 to 40% of individuals. This further destabilizes the glenohumeral joint anteriorly. So all in all, we've got a lax capsule, we've got a poor size ratio, we've got poor congruency of the articular surfaces, and we have ligaments that are very small and are not uncommonly absent. That all these factors contribute to instability of the glenohumeral joint. In addition to the 3 anterior ligaments, there is a ligament called the coracohumeral ligament. This passes from the lateral aspect of the coracoid process, extends down and divides into 2, where it attaches onto the greater tubercle. This overlies the superior capsule and the transverse humeral ligament. And the function of the coracohumeral ligament is to become taut when we've got the dependent arm. So as the arm hangs down beside us, tension in this structure draws the head of the humerus into the glenoid fossa, providing a component of stability as we just let our arm hang down by our sides. The capsule is lined by synovial membrane, which, as with any other joint, it attaches to the articular margins of both the glenoid fossa and the head of the humerus. There is a subscapular bursa anteriorly, which is a communicating bursa that herniates anteriorly through the capsule to separate the tendon of subscapularis from the anterior border of this joint. This is comparable with the iliopsoas bursa down at the hip joint. Also, as the long-headed biceps passes under the capsule to the top of the glenoid fossa, it is surrounded by a double layer of synovial membrane, a synovial tendon sheath, which again is comparable with the synovial tendon sheaths that we see down at the foot and ankle. Irritation of the synovial tendon sheath is not uncommon, which may lead to a tenosynovitis of the biceps tendon itself. There is a non-communicating bursa that sits between the coracoacromial arch and the upper end of the humerus. It's this big blue structure that we can see here. This is a diagram taken from primal pictures. Big blue structure representing the subacromial bursa. It's a non-communicating bursa, and its function is to allow friction-free movement of the humerus relative to the coracoacromial arch. It is prone, however, to impingement and irritation. The glenohumeral joint is inherently unstable. As mentioned earlier, poor congruency of the articular surfaces, the poor size ratio, and the lax capsule all contribute to its instability. The primary stabilizing factors of the glenohumeral joint are the glenoid labrum that increases the articular surface. Most importantly, it's the tendons of the rotator cuff, and anteriorly we have the tendon of the long-headed biceps. There are also large muscles that overlie the joint that help stabilize it. The primary stabilizing factor of the glenohumeral joint is the muscles. Here we have the surface markings of the glenohumeral joint. Anteriorly, it can be identified by palpating the apex of the coracoid process here, passing 1 centimetre laterally. That gives us the centre of the shoulder joint anteriorly, and then we draw a line that is orientated concave, in a concave manner laterally. Okay, so we've got a point in here, we draw a line concave laterally which goes around the head of the humerus. The lateral surface marking of the glenohumeral joint is a line passing through the apex of the greater tubercle. Again, this is comparable to the hip joint, where we have the surface marking of the hip joint being a line passing through the apex of the greater trochanter. The 3 glenohumeral joint ligaments can be identified by identifying the surface markings of the shoulder joint. The proximal attachment is just proximal to the edge of the glenoid fossa over here. The distal attachments are identified by palpating the lesser tubercle. So we could put one goes just above, one goes just below, and then one is just below that, extending down onto the shaft of the humerus. Shoulder is extremely mobile, and when assessing the shoulder joint, the end feel is important to note. It's a multi-axial joint, so we have the movements of flexion and extension, and there's approximately 180 degrees of flexion. This is limited by tension in the antagonistic muscles, in the extensors. Extension is limited by tension in the extracapsular ligaments, and by tension also by in the antagonistic muscles, by the flexors. And there's about 45 degrees of extension typically of the shoulder joint. The movements of abduction, abduction, is approximately 100 degrees. And in this case, if the arm is just kept with the palm facing down, the limiting factor in this situation is where the greater tubercle engages into the coracoacromial arch, a position known as the locking position. Quite a useful movement to assess for the integrity of subacromial structures. The movement of adduction is about 45 degrees, and this time this is limited by apposition of soft tissues, so the body getting in the way essentially. There's about 90 degrees of medial rotation and 90 degrees of lateral rotation of the glenohumeral joint, and this time the movements are limited by the capsule, by the posterior capsule for medial rotation, anterior capsule for lateral rotation, the ligaments for lateral rotation, so the glenohumeral ligaments, and antagonistic muscles for both medial and lateral rotation. So we can see here that the primary stabilizing factors, the primary limiting factors of the shoulder joint are muscles.